Good afternoon, all of you. I think after a heavy lunch, we'll be now talking about weight management in obesity. I don't know how much that will help. Doctor, actually, as we know, any girl we talk to, 90% of them, they have this PCOD or PCOS problems. And definitely that affects fertility. What is your take on that?
I would like to say that today PCOS is overdiagnosed, and it's very important that we do not diagnose PCOS in an adolescent. We need to wait for at least 8 years post-menarche or till she is 18 years. So if you find that the features of PCOS are there in the adolescent girl, we have to label her at risk. And then come to a final diagnosis only when she's 8 years post-menarche or she's 18 years. This is because there are certain features of PCOS which are present in an adolescent, which is physiological. Like a girl who's just got her menarche also will have acne, so that's one of the features. And the other feature of PCOS is basically where we say that she has polycystic ovarian morphology. So that is normal physiological in an adolescent girl. And therefore, most of the diagnosis happens wherein the patient comes with obesity, because nowadays, because of the fat diets as well as eating outside and the lifestyle, obesity is very common, right, in the children as well as when they become adolescents. And so what happens basically is that because of that also they have irregular cycles, and usually in the first 2 to 3 years of the of normal puberty you have irregular cycles, and it takes that much time. So we should not label any adolescent as PCOS till she reaches reproductive maturity, because there are certain features which resemble PCOS are present normally.
Okay. Ms. Swati, are there any specific diet strategies for people suffering from PCOS or PCOD?
Yes, there are definitely diets that can help to manage PCOS and sometimes even reverse. So, to an extent, first thing, it should be a realistic diet plan which can be followed over a long period of time, because PCOD or PCOS is not something just that comes and goes. So, it's a management. So, basically, it would be a lifestyle change, the difference in the way of eating. Second would be physical activity, as doctor was also mentioning. Being active is a very important part. Maintaining your weight, because for most of them who lose weight, maintaining that weight is also very difficult. So the follow-up diet that we give should be more doable. And then of course, certain supplements can definitely help. Even the doctors do suggest, as well as we do.
Doctor, actually, early detection of PCOS or early weight management, how does that help with fertility and PCOS?
Yeah. Usually obesity is seen in about 60% of the women who have PCOS. 40% of them are lean PCOS. Though they are lean, basically they also have visceral obesity, because most of the, especially the Asian population, they are sarcopenic. That is, they have less muscle mass and more fat, and it's basically the visceral obesity. So though it's a lean PCOS, they do have visceral obesity or central obesity, and that's basically related to hyperandrogenism, because we need to know that PCOS is a combination of hyperandrogenism. So when we diagnose, if we see any clinical features, especially hirsutism, more than acne or female pattern of balding, or any other signs of hyperandrogenism, then they should have irregular cycles. So if these two are present, we directly diagnose them as having PCOS. But in case she has only menstrual irregularity and she does not have any clinical features like hirsutism or acne, then we probably do a blood test wherein we look at the androgen levels. And if both are there, then we diagnose them as PCOS. But only if either of them is there, then only we require today an ultrasound where we have a polycystic ovarian morphology for diagnosis of PCOS. So basically, what happens is that we really don't know whether it is obesity which results in PCOS or PCOS which results in obesity. That's still very debatable, because we have evidence for both of them. But it is usually seen that usually the hormonal imbalance which is seen in women with PCOS is exaggerated in the presence of obesity, and therefore the clinical symptoms also get exaggerated. Plus, obesity is associated with insulin resistance and hyperinsulinemia, which are then the main cause of anovulation and several other metabolic dysfunction. Though insulin resistance and hyperinsulinemia is not included in the definition of PCOS, it is one of the main criteria later on which results in infertility as well as in metabolic dysfunction.
Okay. Ms. Swati, today both micro and macronutrients are posing a problem. So how important is it to balance both of them?
Yes, macronutrients, not just counting carbohydrates, proteins, and fats. When it comes to micro, especially in terms of PCOS or if you're trying to get pregnant, is a very important aspect. So, coming to the research, as we have come so many years researching about PCOS, a low carbohydrate diet, or even if we go to keto, that is what we recommend currently for managing PCOS, and along with that a few supplements that we want them to take, so that, as ma'am was also saying, there would be certain features which is showing up and may not necessarily be PCOS altogether. So to manage that as well, like ma'am was saying about acne, so chromium is a great agent to help with acne reduction. So such things can be added into their diet via food.
Okay. Doctor, sometimes just lifestyle changes will not help. Like some treatments like ovarian drilling and ovulation induction therapies are also there. Can you elaborate on them?
The treatment basically in a patient who has infertility will depend on several factors apart from having PCOS. One is age of the patient. So if the age of the patient is more than 35 or 36 years, it's best to go on with the treatment for infertility straight away and not wait for lifestyle interventions. Duration of fertility, if it is more than 3 years, plus if there is presence of any other infertility factors, like if the patient has associated endometriosis, she has associated adenomyosis, fibroid uterus, or she has infection because of which she has blocked tubes, and there is a male factor, then basically we should not wait for lifestyle. If she is less than 30 years, yes, we should surely give her at least 3 to 6 months for reducing her weight, because that might result in a spontaneous pregnancy also, or it might decrease the amount of drugs we give and also improve the success with the treatment what we are offering. And the best drug, the drug what we use is, we start with the oral ovulagens, and what we use today is letrozole. And it is normally given for 5 days from day 3 of the cycle till day 7. And then the monitoring of the follicular growth is very, very important, because it does not make sense when you're taking the tablet and you tell the patient, oh, you have sex on alternate days, because many times they do not respond. So we have to know whether they respond to the drug or not. So that's very, very important. So from the 9th day onwards, I think doing follicular monitoring either daily or on alternate days is important. Once the follicle is about 15 to 16 millimeters, probably you need to do it more regularly, because the follicle can rupture at any time. Because once the egg is released, basically, though it is alive for 24 hours, it's fertilizable only for about 12 hours. And therefore, knowing the exact time is important. If she's resistant to letrozole or she does not conceive with letrozole, then one can go for clomiphene citrate. But with clomiphene citrate, the disadvantage is that many a times, because of its anti-estrogenic effects, it results in a thin endometrial lining. So in these cases, probably tamoxifen, which is also a estrogen receptor agonist, can be used. If the patient fails to conceive with either the oral, either clomiphene, letrozole, or with tamoxifen, then we need to go for gonadotrophins. Though initially ovarian drilling was considered as a second line of treatment, all the recent evidences are against doing ovarian drilling, because it has been seen that many a times ovarian drilling causes loss of follicles, and then the patients have premature menopause, and it can also result in adhesions if it's not done properly, and this can then prevent a natural conception, and then you have to go for basically for ART.
Ms. Swati, sometimes it happens that, from what I've heard, people with PCOS and all have these cravings for eating things. Is that true? And if yes, then how do you actually manage them?
Yes, they do have a lot of emotional eating, or I would say binge eating. So this is mainly to do with what ma'am was saying, hyperinsulinemia. So this just doesn't mess up your insulin, but also messes up your brain. So it almost shuts down your cortex, which is the main area where you will be able to make logical judgments. So this is a calling towards food when you're really not hungry. So you just satisfy your other feelings through food. So one way to overcome this situation would be have lot of variety. So the more variety available in food makes them more available for options they can snack on. Second, the options should be healthy. Mindful eating, that is what we say. And the third would be portion control.
Doctor, how does weight actually influence miscarriage and infertility? What are the complications generally for obese people?
Yeah. So basically, we can divide the effects of weight into several categories. One is it affects the hormones. So whatever hormonal abnormalities there, it is enhanced by obesity. Like the insulin resistance is increased, the insulinemia, there's hyperinsulinemia is increased, the hypoandrogenemia is increased, and basically directly it can also affect the ovulation. Second is when we are treating the patient, obesity increases the amount of drug which is required. It can extend the time of ovulation, that the number of days required for ovulation. Plus, in a patient who is not taking treatment but is ovulating, like you have 4 phenotypes. So there is an ovulatory phenotype also wherein the patient ovulates, that is the phenotype C which is there. So these patients are ovulatory, but then it can delay the conception in this group of patients. Once pregnant, it increases the chances of miscarriage, and this is basically related to hypoandrogenism as well as hyperinsulinemia. And along with that, it has been seen that those patients who have basically high AMH values and who have an abnormal glucose hemostasis in the blood, hyperhomocystinemia, which is also seen in patients who have PCOS along with vitamin D deficiency. This increases the chances of preterm delivery, of miscarriage. Then there's also an increased chance of preterm delivery which is seen, and usually pregnancy associated complications like pregnancy induced or hypertensive disorders of pregnancy and gestational diabetes has a higher incidence.
Okay, Ms. Swati, about nutrition. Now, when a couple is undergoing fertility treatments, how much does diet influence and what is the success rate you have seen?
So weight loss, as ma'am rightly said, is a very important aspect, and even a 5% weight loss can account to a lot of fertility betterment, or I would say the quality of the embryo is better and her chances of ovulation also increases. So maintaining a healthy weight and having a gradual weight loss is very important. And definitely people who are trying to conceive, even naturally as well as assisted, should definitely opt for weight loss if they are in the overweight or the obese category. Otherwise, should at least adopt to a healthy lifestyle.
And doctor, what are the latest technology available to treat PCOS?
Pardon, I didn't get.
Latest emerging treatments and technology to treat PCOS.
So basically, there's nothing new which is there in ovulation induction. So it's basically use of the oral ovulants which we were using for so many years. When we talk about the gonadotropins, we can use, though we have recombinant gonadotropins now, but it has been shown with several RCTs as well as the Cochrane report has shown that there is no difference in the pregnancy rates as well as ovulation rates, whether you use a recombinant gonadotropins or you use urinary or ultra pure gonadotropins. There's a new concept now which has developed that talks about the gut dysbiosis. It's said that PCOS is associated with gut dysbiosis, and therefore probably treating these patients with prebiotics and with probiotics may be helpful, and more so in obese patients because obesity definitely alters the gut microbiome. Then coming to the insulin sensitizers, basically what we are using year long for more than 100 years is Metformin, and it is supposed to be very effective, though it has some gastrointestinal side effects. But in some patients who cannot tolerate Metformin, probably inositols can be used, but the evidence for using inositols is not much, and basically it is a nutraceutical and it's present in the normal diet what we are having. But now we are having the GLP-1 analogs which have come into the market. In India, they've just come recently, and they include the liraglutide and the semaglutide. The liraglutide is basically injectable, whether the semaglutide is an oral preparation. And this helps in reducing the insulin resistance, as well as it also helps in weight reduction. So it is more effective in reducing the weight as compared to Metformin when the GLP-1 analogs are taken.
So Metformin is something which is widely accepted for fertility treatments. Metformin is widely accepted for fertility treatments.
Metformin itself does not cause ovulation. Basically, when you add to oral ovulants, like if the patient has not ovulated just by giving clomiphene or letrozole and you add Metformin to it, it has been seen because it reduces the insulin resistance, it increases the glucose uptake in the muscle, so the glucose hemostasis is achieved. And basically, it also has its effect on the liver, where it increases the sex hormone binding globulin, because if it is reduced, the free testosterone or the androgens are more, and the estrogens also are more, and this can affect the ovulation as well as the growth of the follicle. So it increases the SHBs in the liver, and therefore the free testosterone and the free androgens also reduce, and therefore it improves the ovulation rate.
Ms. Swati, you were mentioning about supplements. Can you precisely tell us what are the supplements to be given to PCOS people?
Sure. So mainly we concentrate on few of them. The first one would definitely be vitamin D, because research has shown that severe vitamin D deficiency is mainly associated with insulin resistance and also increased risk of cardiovascular disorders and decrease in the production of healthy eggs. And the second supplement that we would definitely recommend is omega-3 fatty acids. As we know, it's an essential fat, and essential fats are very, very good for improving the health of the embryo as well as proper ovulation. It also flushes out the bad cholesterol, keeps you healthy, keeps you active. Then third definitely is folate. So folate, as doctors also prescribe it pre-pregnancy. So this also improves the quality of embryo, and to an extent it also improves your insulin sensitivity. And there are definitely other small ones, like I was talking about chromium and inositols. These are also recommended, and to an extent even cinnamon extract.
I think folate is advised immediately when they plan for conception itself.
Yes.
Doctor, so what basically when we're talking about the nutraceuticals, I would like to add that probably CoQ10, which is an antioxidant, helps in women with PCOS, because usually these women have the oocytes, because of the abnormality in the hormones, have a lot of mitochondrial dysfunction. And this mitochondrial dysfunction then can affect the fertilization rate as well as the embryo formation rate. And therefore, giving CoQ10 in this group of patients would really help them in conceiving.
So, Doctor, what is insulin resistance in PCOS, and how does it come in the way of natural conception?
So basically, what happens in PCOS is that there is a insulin receptor dysfunction, and this then is seen in the pancreas. This results in increase in the secretion of insulin. This secreted insulin has different effects on different organs in the body. So in the liver, basically it reduces the sex hormone binding globulin, and therefore there's increase in the androgen levels. It also acts on the adrenal gland, where it increases the DHES, and it also acts on the ovaries itself. So in the ovaries, you have the egg, you have the granulosa cell which covers it, and then you have the theca cells. So it is the theca cells which produce the male hormones or the androgens. So what does insulin do is it increases the production of androgens over there, and it decreases the ability of the granulosa cells, because this androgen which is produced in the theca cells goes into the granulosa cells, and here it is aromatized into the female hormone or estrogens. So it prevents the aromatization of the hormone because there is reduction in the P450 alpha 17 alpha enzymes which are there, and therefore it again increases the androgen levels. And therefore as it is, the PCOS women have high androgen levels, and this hyperinsulinemia in turn increases the androgen levels. Moreover, in the muscle, it decreases the uptake of the glucose, and therefore what happens, there is impaired glucose tolerance, or there is also basically diabetes mellitus, and in the adipose tissue it increases lipolysis with dyslipidemia. Moreover, it also has action on the follicles. So in the follicles, because of the high androgen levels, it inhibits the meiotic changes, because all the eggs are basically arrested in 46 chromosomes, and if they have to be fertilized, they have to there has to be a reduction division to 23, which does not happen. And as it is, obesity which is there and is one of the main features of hyperinsulinemia and insulin resistance, basically results in inflammatory changes, and therefore the endometrial receptivity or the acceptance of the endometrium to the embryo is also affected.
Ms. Swati, there are so many popular diets like intermittent fasting and many other diets. Do they actually work for PCOS?
Yes, but to an extent, how much would you be able to follow? As I was saying earlier, there is ketogenic diet, there's even intermittent fasting. So intermittent fasting is actually not a type of diet, it's a way of eating. So when you follow it, if your adherence is 100%, then definitely you will be able to see the results. But mainly for PCOS, I would say intermittent fasting is a great way of eating, because you're eating according to your circadian rhythm, where your insulin is high or where the production is good, that time you're eating mostly, and where your insulin needs rest or keep up its sensitivity, that is during the night, you're not eating.
Doctor, what is your final piece of advice to our audience watching you? Your final piece of advice to the audience who are watching you?
Yeah, so basically one must know that there's an intrauterine origin of PCOS, and this is related basically to a lifestyle. And because of obesity or an altered lifestyle, or if the mother herself is having PCOS, or she smokes or she drinks, there is abnormal environment in the uterus, and this then results in several affections of the fetus, wherein there could be miscarriage, there could be decreased growth of the child, and they also could be epigenetic and genetic abnormalities. This decreased growth of the child is called as a thrifty phenomena, and when the child is born, it starts getting abundant food, and because of that, they put on weight. And this then results either in early menarche, or it can result in menstrual irregularities, it can result in obesity, and today we know that obesity has become a pandemic all over the world, and I think it's because of our lifestyle. And I think most important, I feel, is that we have to improve our lifestyle. We should not eat much outside, because when we eat outside, we cannot control what we are eating, and therefore healthy eating is very, very important. And once they reach their menarche, again, we have to look at their weight gain, and also we have to look at their mental health. That is very, very important, because it has been seen that if you have there's a lot of competition, and there's a lot of stress, there's a lot of anxiety. This in turn then alters the hormonal imbalance, and this can trip your balance, and you can still become, develop symptoms of PCOS. Moreover, now we've seen there's a lot of, sexual, pre-promiscuity which is there. And because of that, the girls have started taking oral contraceptives. This again can affect your hormonal imbalance, and that can also, lead towards your PCOS. When you come to your reproductive life, it's again weight control, lifestyle, and it's best to conceive earlier. And if not possible, because today, because of their education, because of their work, they might not be able to want to conceive early. So then we still have the option of going for social egg freezing. So your eggs are basically of younger age and whenever you want, till the age of 40 or 45, because in India we cannot do IVF for a patient who is more than 45 years of age is one of the options which is there. But I think lifestyle is the most important, and in this, apart from your diet and exercise, sleep is very, very important. Reducing stress is important, as well as avoiding smoking as well as alcohol, because I think that's become very common.
Ms. Swati, would you like to tell anything to the couple who are looking at weight loss?
Sure. So the main thing here is knowing your food. So knowing what can cause the insulin surge. So if you know the foods that can have controlled surge of insulin and still get your energy from that, so that could help. Giving a diet plan which is very easy for them to follow and they would keep it consistent. Third, when you go out, especially as ma'am was also mentioning, don't resort to junk food. Eat mindfully. Choose the snacks very wisely. And fourth, definitely lifestyle. Keep yourself active, exercise, or at least do any physical activity that keeps you happy, because happiness is something which goes against the cortisol.
I think an anti-inflammatory diet is very, very important. And I would also, my last message would be that PCOS starts in utero, and therefore the mother-to-be has to take care. Then she has to take care as a child, and the child, when it becomes big, also needs to take care. So this is a very important message, I think, which we need to know. And it is the male siblings also have PCOS. There's something called as male PCOS, wherein it has been seen that the male siblings and the male relatives of the female PCOS are having a higher incidence of metabolic disorders like diabetes mellitus. They have increased incidence of hypertension and cardiovascular disease.
So consistency is the key for weight management, I would say.
Yeah, I mean, weight management definitely reduces the incidence of cardiovascular events, and also it keeps your diabetes and hypertension under control. So as I said, lifestyle modification is the most important thing when we talk about PCOS, and one must remember that's only not in the female, but it's also in the male.
Thank you so much for being on the panel.
Thank you.
Thank you, doctors.
Thank you.
ನ್ಯೂಸ್ ಫಸ್ಟ್ ನಿರ್ಭೀತಿಯಿಂದ ನಿಮ್ಮ ಪರವಾಗಿ.